Good afternoon, everybody. Dr. Michael Jacobs here at the Fertility and IVF afternoon in Instagram chat. This is Fertility Awareness Week, and we welcome you all here to share this with us. Today's an open forum, so if you have questions, please go ahead and write them in, and I'll try and answer as many as I can. I've got a couple that people asked ahead of time. It's nice to have everybody join in. We've got around 25 people right now, and usually, about twice that'll enter, and then people look at it online. So these are posted on our website, so just feel free to go on there and access our Instagram talks. There's about 25 of them at this point, and feel free to comment or send us some recommendations of what you want to hear about. One of the common questions that we've gotten that people always ask is, how do I get the best stimulation for IVF? Particularly people who are poor responders to medication, what do we do to get them to respond better? And the first thing that's important to understand is that a poor response isn't due to the medication not working properly. It's really the quality of the ovary that we're working with. So whenever we assess an ovary, we try and gauge what's the person's ovarian reserve status before we get started. And to do that, we look at a couple of parameters. The first thing is, how old are you? In general, the older you are, the less good quality eggs you make. The second is the biologic markers that go along with that, which is FSH and estrogen determinations on cycle day 2, 3, or 4. Antral follicle count measurements of the ovary on the same time period, and an AMH, anti-Müllerian hormone level. All those things give us an idea of how the ovary is going to respond. Many times they're all in unison with one another. They all give us the same predictive value. Sometimes we'll see one saying something better than the other one, and we try and put it all together and figure out what the best response for the patient is going to be. But if you're having a poor response, then the first approach is, let's increase the medication dose. And so an ovary that's more resistant to medication, less sensitive, have less good quality eggs, often if we'll increase the dosage of medication, we get more responses. And in general, women that are older use higher doses of medications than women that are younger. We also can do some priming of the ovary, and sometimes we find patients do better with what's called estrogen priming, where we start some estrogen about 7 to 10 days before a period comes down, and that somehow decreases the FSH level if it's a little elevated, or also free up some of the receptors on the ovary, or prime the receptors theoretically, so that when the injectable fertility drugs are started, you have a little better response to it. Sometimes we find patients respond better with nothing ahead of time. We just wait for a period and then start them up. So there's a lot of kind of art involved with deciding, do we use a birth control pill? Do we use a spontaneous cycle? Do we use some estrogen priming? If those don't work, there are a couple of older techniques that we occasionally might try. One is called a microdose Lupron flare, rather than using an antagonist protocol. And lastly, and paradoxically sometimes, there are patients that are very resistant to high doses of injectable fertility drugs, but for whatever reason will produce the same limited number of eggs with what's called the mini-stim approach. And mini-stim can have different connotations depending on who's using that word. When I use it, it's usually meaning a combination of an oral ovulatory drug like Clomid, followed for 5 days, followed by very low doses, about 150, at most 225 units of the injectable fertility drugs beginning on the 7th day, which is the 5th day of medication treatment. That's to distinguish a mini-stim. We're using a combination of Clomid and low-dose injectables with what's called a low-dose stimulation. Some people do use the term mini for that, where they're using like 150 units of fertility drugs instead of much higher doses in people who don't respond well. And using less injectables usually doesn't improve things. Sometimes if you have someone who's proven to be a poor responder and makes a limited number of eggs, the mini-stim will give us the same number of eggs, or sometimes paradoxically more, and cost 1/4 of what the fertility drugs cost when we're using the high doses. One person asks, why don't we use that all the time then? And the reason is you don't get a ton of eggs. We usually will get 1 to 3, and occasionally we might get 5, but we're not going to get 10 or 20 eggs with the mini-stim approach. And in reality, as someone else had asked, if you're looking at why do we want more embryos instead of less, is because no matter how old you are, a certain percentage of embryos are not going to be normal genetically, and the older you are, the poorer your ovarian reserve, the higher percent that are abnormal. So it becomes a little bit of a numbers game. If we know if you're 42 years old and 80% of the embryos aren't going to be normal, if I got 10 embryos to work with, which is very rare in that age group, I have a chance of getting a normal embryo. But if we only have 2 or 3, many times we get skunked and we don't have a normal embryo to work with. Whereas in someone who's 33 years old, where 70% of the embryos are going to be normal, even if we only have 5 or 6 embryos develop, odds are we're going to have a couple of normal ones. Someone had asked, what are the non-injectable medications? What can we do to increase egg quality over time? Is there anything that we can do nutritionally or otherwise? And the answer is yes, but a lot of the data is just not proven. So I'll go over the things that we all think about. Certainly, eating a healthy diet is a good idea. Having a normal lifestyle, decreasing stress in your life as best possible, although it's hard to eliminate that totally if you're going through IVF treatment. And then some nutritional supplements, a lot of people feel are helpful, but the data supporting its use is really very minimized. But in general, we have a vitamin supplement booklet that's available for anybody that wants to look at it. If you just call our office, we'll email it to you or pick it up next time you come in. But other than a prenatal vitamin and making sure your vitamin D levels are okay, we recommend DHEA, which 25 milligrams 3 times a day or 50 milligrams twice a day, whichever you can get. We recommend L-arginine, which is a amino acid, and that comes 500 milligrams once a day, and CoQ10, 200 milligrams daily. Those are the 3 main ones. Some people use omega-3s, which are fine. If you're eating a couple portions of salmon a week or fish, you'll probably get a fair amount of omega-3s in your diet naturally. Royal jelly, which is an extract of bee honey, I believe, is okay and no harm done, but I'm not sure it really does anything good. So the key ones to me are DHEA. That probably has the most written about it. There have been a couple case reports, no study of hundreds and thousands of patients, but there have been case reports of 20, 30 patients put on this, and over a period of 3 or 4 months, they seem to have a little better quality or a little better response. It doesn't fix the AMH level. It's not going to make your 42-year-old overreact 32, but it may help out. Similarly, acupuncture. Acupuncture is Eastern medicine approach. Most patients who do acupuncture find it very helpful in decreasing their stress levels. The acupuncturist will feel that it helps increase uterine and ovarian blood flow. There's no data that it does any harm. If you look at a lot of data, we're not sure it does any good, but it doesn't do any harm. And I have no problem with a lot of our patients seem to enjoy the experience, and if it has a benefit, terrific. How acupuncture equates to increased fertility in Western medical standards is difficult to explain, but there are benefits with stress. There's increased blood flow, and if that results in a better response and a healthier ovary, so be it. But certainly no objection to that. One of the problems with the studies that are out there with acupuncture is that different acupuncturists use different approaches. The timing of the acupuncture relating to fertility drugs and relating to egg retrieval, and probably more importantly embryo transfer, is very variable. So it's very hard to compare one person's approach to the next. The people that we do work with in Miami seem to do a good job, and patients enjoy the experience, and in some patients it seems to have made a difference. What are ways to improve sperm health and egg health quality? We talked about vitamin supplements for women, vitamin supplements for men too. If you want to buy them online, Coast Reproductive Vitamins, now called Fertile One for men, are fine. It's a multivitamin that really is associated with antioxidants and the presence of carnitine, which is an amino acid that's sperm friendly. Locally at CVS or Walgreens, Fertile Blend for Men is very similar in that regard, and can be useful in that sense. One question is, how do we know that we're getting the embryo in the right spot when we do an embryo transfer? That's a great question. For those of you that are patients, you know we've done ultrasounds many times. We also have done usually a hysteroscopy or a hysterosalpingogram, so we have an idea of what direction the cavity is in and what angle it's at. And if we've had a hysteroscopy, we do a uterine cavity measurement at the time. That tells us the distance from the outside of the cervix to the mid-fundus, so sort of what's the maximum depth of the cavity, basically. And when you do an embryo transfer, you want to transfer less than that. You don't want to you don't want to put something in the door and go all the way to the wall. You want to be about 2/3 into the cavity, or 1 centimeter to 1.5 centimeters from the upper wall of the inside of the cavity. We do what's called a mock embryo transfer, and different centers, different fertility programs do this at different times for different reasons. We found we get our best results and our best time to do this is actually immediately before the embryo transfer. So we do a couple things. One, most patients have had a hysteroscopy done in the office, so we can actually measurement. We have that measurement recorded ahead of time. Two, before I do an embryo transfer, with ultrasound guidance, but I'll usually do a vaginal ultrasound, and that's just to measure the length of the cavity from the outside of the cervix to the upper part of the fundus, to confirm if that's similar to what we measured previously, as well as to confirm the angulation between the cervix and the uterus to see which way the catheter is going to go. The third thing we do when a patient comes for transfer, we'll put a speculum in, we get them in examining position, we wash the cervix off with first some saline and then some culture media, and then we do a mock transfer. And we do this with trans-abdominal guidance, where we have a ultrasound probe pushing down on the bladder right above the pubic bone. And in most patients, we can see a pretty good outline of the cervical canal and the uterus. Now, in some patients, either because they have more BMI and you get less penetration of the ultrasound image, or the uterus is pointed backwards, it may be more difficult to actually guide the catheter with ultrasound abdominally. But in most patients, we can see pretty good. And we do a mock transfer, and we don't do the mock transfer to measure the distance. We do the mock transfer to assess which catheter is going in. We've already measured the distance both hysteroscopically and by ultrasound appearance, and since in most cases we're able to do a ultrasound guided transfer. We can see where the top of the fundus is and where the catheter is, so we know where it is. We want to try and minimize the trauma to the cavity as best possible. So what I'm looking for is, can I get this catheter through the cervix easily, and which catheter do I need to use? And our preference is use as soft a catheter as possible. So we usually use what's called a Wallace catheter, a very soft catheter. It does not have an inner guide to it. And we do the mock transfer. We're just going through the cervix right to the entrance of the uterus, basically. We don't want to go way up in the top of the uterus because we don't want to traumatize anything. But we go just enough to know it made it past the curve, past any irregularity that might be there from prior cesarean sections or just the angulation of the cervix in the uterus, and make sure we get the catheter into the cavity. If there's resistance or there's sharp angulation and the very, very, very soft catheter will not negotiate that curve, basically, then we use a catheter that has an inner stent in it. It's got the nickname of a TDT catheter, tight difficult transfer catheter, and it's just a catheter that we can put a bend into so that we can angle it to try and get around a corner, and we can also see that catheter a little more easily in patients who have a position of the uterus that you can't see that easily, to just, again, reconfirm that it's in the right spot and it's made it past the cervix into the uterine cavity. We aim to put the embryo in the mid-fundus and the mid-uterus. It's usually a centimeter to a centimeter and a half from the upper part of the cavity. When you're looking at this from the patient's perspective, sometimes it's hard to figure out what we're looking at. We're just seeing a very faint dot, a little white dot on it going into the uterus. That's the tip of the catheter, basically. And when the actual embryo is expelled into the uterus, because it's in a little bit of culture media with a small air bubble behind it to help push it out, it's that interface that shows up as an echogenic reflection on the ultrasound. You see like a little flash on the inside of the cavity, and that's the embryo being deposited. Once the catheter is removed, it's going back to the laboratory where they check to make sure it hasn't been cobwebbed and nothing is stuck on the outside of the catheter. So the actual embryo transfer process is usually fairly straightforward and quick. It's the preparation to get everything all set. The lab then brings the embryo out. We put the embryo in. Before we reposition you and stuff, the catheter will go back to the laboratory, evaluate the catheter tip and make sure nothing is being trapped within the cervical mucus at the end of the catheter tip, basically. And that's how an embryo transfer is done, and ultrasound guidance is used to mostly reassure ourselves that the catheter tip didn't get turned around on itself or anything, and it just helps to, particularly in a patient that's got a very curvy or one where we've got to kind of change the position and wander in the catheter as it goes in. It's helpful for us to stay on the road, basically, instead of doing it blindly. Next question was, how do we decide if we want to do intrauterine insemination or IVF as the best means of getting pregnant? If we've got unexplained infertility, if we have good ovarian reserve, if we've got a mild male factor, often we'll start with a combination of a fertility drug and insemination first. If we've got evidence of tubal disease, if we've got diminished ovarian reserve, long-standing infertility, history of prior miscarriages associated with infertility, where there's some benefit of doing genetic testing before embryos are transferred, then certainly going to IVF sooner rather than later is important. An interesting question from Sally was, in patients who want more than one child, does that change how we might want to treat somebody? And the answer is yes, but not because we're trying to get multiples. Our recommendation is not to transfer multiple embryos. Our recommendation is to transfer only one embryo in a cycle. If you look at our data for the last couple years, our average number of embryo transfers per patient are about 1.1 or something. So occasionally there's a reason that we might want to transfer two for a couple, but in almost all cases we're transferring a single embryo, particularly if they're good quality and they're embryo biopsied and euploid PGT tested embryos. So single embryo transfer is our best outcome. But if you're, if we look at somebody who's 23 and they want to get pregnant, but they also want 2 or 3 kids, there's no, they can get pregnant, be pregnant, have a baby, wait 6 months, get pregnant again. And so in that particular patient, we're not really worried about after their pregnancy is complete, are they going to be in a much worse spot than they are right now. But if you're, let's say, 39 and your ovarian reserve is a little bit low, we know it's hard to get normal embryos and a lot of embryos. If we do IUI and you get pregnant, that's great. But by the time you have a baby, give birth, and wait 6 months, we're now a year and a half later, and now you're 41 basically, or 42 in some cases if you started a little bit later. And we know that as you get older, it's harder and harder to get pregnant. Ovarian reserve goes down. And so if you want to have 2 kids, we don't want to put 2 embryos back at a time, but it would be nice if we could treat you to get pregnant and at the same time do something to preserve your fertility for the future. And so we do have a discussion with patients about embryo batching, particularly IVF patients, in that if you're 40 years old, 39, 40 years old, and we're doing IVF, and let's say we have, 2 normal embryos to put back, and now we have to plan your embryo transfer cycle. Well, we know anytime we transfer a embryo that's normal into the uterus, whether you're 25 or 40, the chance of that embryo being successful, if it's a normal embryo, is about 50%. So if your goal is you just want to have 1 child, and we have 2 embryos, doesn't matter, that's great. We put 1 back. If it works, it works. If it doesn't work, we put another 1 back. Hopefully one of the 2 has worked, and you're done. You have a baby. But if you want more than 1 child, and you're 40 years old, and we do that, and you get pregnant, you now have your baby, you wait 6 months, and now, okay, Dr. Jacobs, I'd like to get pregnant again. Now you're almost 42 years old, and it's a lot harder. The aneuploidy rate continues to go up. The ability to get a lot of eggs continues to go down. So our chances of getting you pregnant is less. So if we have a patient who's, in their late 30s, particularly early 40s, and they want to have more than 1 child, then we'd like them to have more embryos available. And I would say a good rule of thumb is if you've got 3 euploid embryos in the freezer, odds are one of those 3 is going to result in a pregnancy and a baby. So having, if you've got 4 embryos and you want 2 kids and we put 1 back and it works, that's great. You got 3 more left over for down the road. That's terrific. But if you only got 1 embryo and you get pregnant, then we're going to be starting all over again down the road, and we're not doing anything to preserve future fertility. So thinking about the future and what your needs are down the road, as well as the present, is very important to incorporate both of those thoughts in helping make a decision. So those are just some of the questions asked today, and I appreciate everybody joining in and focusing on fertility, and we're here for you to help you get pregnant, be pregnant, have a safe pregnancy, and to do it in as cost-effective and practical manner as possible. So have a good day, everybody, and wish everybody well. Bye-bye.